The only person in this conference.
Hello, guys. I'm sorry I'm late a little bit. I hope you are all right and doing well. Um, Without any further delay, I think we can start today's exercise. Unless you have any questions. Um, you can hear me, right? Just to confirm. Okay, great. So I'll start sharing the presentation now. Today's exercise is going to be about rational drug therapy of diabetes. And it is one of the also more important exercises, since diabetes is a disease that no matter what specialty you are going to choose in your career as physicians, you are all going to meet. That's why you have to know about this disease and the drugs that are used in the treatment of this disease. First of all, it's a chronic systemic disease characterized by metabolic but also vascular abnormalities, which can be divided into micro and macro angiopathies according to the size of the vessel that this disease causes any abnormalities in. It's a disorder of the carbohydrate metabolism and results from either inadequate production or maybe no production at all of insulin, or underutilization of insulin, for example, due to decreased sensitivity of the insulin receptors to insulin. So when diabetes becomes symptomatic, the symptoms are usually due to hyperglycemia and glycosuria. And as you probably know as well, we usually divide diabetes into two types, type 1 and type 2, but there are also other types like gestational diabetes, diabetes insipidus, which is totally non-related disease, but it's nonetheless called diabetes insipidus. But in this exercise, we're mainly going to focus on the diabetes as we know in general, or diabetes mellitus, mostly type 1 and type 2. As you know, type 1 is relatively less common, so around 5 to 10% of all patients with diabetes have type 1, and 90 to 95% of patients have type 2 diabetes. In type 1, patients usually do not have any secretion of insulin, and the cause is usually autoimmune, although sometimes no specific cause is found. It can be diagnosed after a viral infection, after an autoimmune disease, or it can be just idiopathic, so no known cause for type 1 diabetes. Type 2 diabetes patients, they have some insulin levels, so their pancreas are working and they are secreting insulin, but usually this insulin is either not enough or the insulin receptors are resistant to this insulin that is being secreted by the pancreatic cells. Symptoms of insulin, again, when it has become symptomatic, it is related to hyperglycemia, glycosuria, polyuria, polydipsia, polyphagia, and sometimes itching. But type 2 diabetes, as you know, can go on for years and years without the patient having any symptoms. especially in patients who don't go to regular medical checkups, who don't measure their blood glucose levels, no laboratory tests, etc. But in type 1 diabetes, usually patients, because they have such a sudden onset of symptoms with polyuria and polydipsia, so they are drinking too much water, they are eating more than usual, and they are also urinating more than usual. Um, it is easier to for the patient himself or herself, or the patient's usually parents, because type 1 diabetes usually starts in childhood, to notice the symptoms and seek medical help faster, because the symptom onset is very sudden. In diabetes mellitus in both types, usually the fasting glucose level is higher than 7 millimoles per liter or 126 milligrams per deciliter. You see that there is a difference between the units that are used to measure the blood glucose levels. Some countries, millimoles are used; in other countries, milligrams per deciliter. In Bulgaria, we usually use millimoles per liter, but in the US, in Germany, I think also in Greece and in Turkey, milligrams per deciliter are used. But if you ask me, I think you should know, if not exactly how much, like 7 millimoles is equal to 126 milligrams, at least have a understanding. Let's say if your patient comes from a country that uses milligrams per deciliter, but your country uses millimoles per liter, and your patient tells you that the blood glucose that was measured is 200 milligrams per deciliter, at least you should know that it's high enough when it's fasting blood glucose to be able to diagnose diabetes, or at least that it is a high level and not a normal one. Normal is less than usually 100 milligrams per deciliter in these units. So patients can have also weight loss, weakness, increased frequency of infections due to the higher levels of blood sugar. And without intervention, diabetes mellitus, no matter which type 1 or type 2, leads to significant complications, especially vascular complications. And vascular complications lead to retinopathies, because the retina is supplied by small blood vessels. Glaucoma, also neuropathies. There is a special type of neuropathy called diabetic neuropathy that usually involves the lower extremities. Cardiovascular disease, very common in these patients. And another thing to keep in mind is that patients who have diabetes, especially those who are on insulin or who have suboptimal control or very high levels of blood glucose, and this has been going on for more than a couple of years. When they have an ischemic incident, especially cardiovascular ischemic incident like a myocardial infarction, they may be totally or partially at least symptom-free, meaning that angina is not very typical in these patients. So you should look for other signs of myocardial ischemia in patients with diabetes. If your patient tells you that he or she doesn't feel any pain or any angina or chest pain, it doesn't mean that the patient cannot be having a myocardial infarction. Peripheral vascular disease also during pregnancy, complications are more common in patients with diabetes mellitus. And again, there is a specific type of diabetes during pregnancy. that is called gestational diabetes. And I think you have to be studying about gestational diabetes in your obstetrics classes. So we won't be talking about gestational diabetes in this exercise. Here, another very important table that maybe can help you during the exam. Also, if you know at least several important things that are written in this table. So there is something called pre-diabetes, when the levels of blood glucose are not enough to make the diagnosis of diabetes. And this is so when the fasting plasma glucose level is between 100 and 126 milligrams per deciliter. And this is equal to 5.6 to 7 millimoles per liter in terms of millimoles. And we can make a diagnosis of diabetes when the fasting blood plasma levels is again over 126 or 7 millimoles per liter, depending on the units that we use. If the patient has, let's say, a random glucose level measurement, doesn't matter whether if it's fasting, if it's after eating or drinking anything, if the patient's levels are over 200 milligrams per deciliter, or this is equal to 11.1 millimoles per deciliter, this is enough to make the diagnosis of diabetes. Also, according to the American Diabetes Association and also NICE, NICE, as you know, these are the National Institute for Health and Care Excellence in the UK. They also use glycated hemoglobin to make a diagnosis of diabetes, but the WHO or the World Health Organization does not recommend the usage of glycated hemoglobin for diagnosis of diabetes. We use this very important laboratory tool to follow up patients with diabetes, because it shows the blood glucose levels in the past 3 months. So if your patient insists that his or her diabetes is under very good control, and they come to your office with a normal blood glucose level, but you see that there are some vascular complications, and the patient's other laboratory tests are not so positive. You can also measure the glycated hemoglobin level, and if it's over 6.5, it's an indication that the diabetes is not really well controlled, and your patient is not compliant to the therapy that you assigned. What's the pathophysiology of diabetes? Well, insulin is secreted by the beta cells in the pancreas, and it usually binds and activates a big percentage of cells, and these cells are found in the liver, in muscle, and also in fat cells. And insulin receptor binding enables the glucose to enter the cells and to be used as a source of energy. And this is very important for also neuronal cells and again muscle cells, because they are using glucose at a very high rate, and they're very energy dependent. So also increased permeability allows for amino acids and fatty acids and electrolytes to enter the cell, and it also affects anabolism and catabolism of cells. Insulin besides that, increase glucose transport into liver, skeletal muscle, again, adipose tissue, the heart, also the uterus, and it's a must uh, for it to be present so that muscle cells and neuronal cells are able to use glucose for energy. Um, okay. After breakdown of glucose, we have several products like glycerophosphate, fatty acids, and triglycerides. And also, this is the mechanism by which insulin promotes fat storage. When, however, insulin is lacking, so that glucose cannot be used, fat is another source of energy, and it is being released into the bloodstream as free fatty acids. And um, fatty acids are starting to be used as sources of energy. This is related to also a complication of diabetes, like diabetic ketoacidosis, that happens in type 1 diabetes usually due to the breakdown of fatty acids and amino acids and the formation of ketones. And the ketones, as you know, are acidic, so the blood pH is falling. And that's why it's called diabetic keto, because of ketones and acidosis. So the blood pH is low. Glucose is the major stimulus of insulin secretion, and one interesting and also important thing is that oral glucose is usually more effective than intravenous glucose to increase the secretion of insulin. And this is uh, an important point to keep in mind when treating such patients, because when you give your patient oral glucose, um, this glucose in the digestive tract, in the gastrointestinal tract, leads to an increase of gastrin, secretin, cholecystokinin, and gastric inhibitory peptide, or GIP, secretion, which of course help the secretion of insulin. So it is especially important in um, hypoglycemia, to keep this point in mind. And when you give intravenous glucose, because there is no activation of these um, molecules in the gastrointestinal tract, less insulin is released by the pancreas, by the pancreatic beta cells. Also, endogenous insulin is related to other hormones, which, when they're given either exogenously or when there is an increased endogenous secretion of, let's say, cortisol, glucagon, growth hormone, epinephrine, estrogen, and progesterone, this also leads to a raise in the blood glucose levels. Insulin secretion is inhibited sometimes by hypoxia, also by hypothermia, and by stimulation of alpha-adrenergic receptors. Type 1 diabetes, we said, results from an usually autoimmune disorder, but also it can be of totally idiopathic cause and leads to a destruction of the pancreatic beta cells, which we said are the producers of insulin. So when there are no beta cells, there is no possibility for insulin to be produced inside the organism, and that's why we need to supply this organism by exogenous administration of insulin. It usually has a sudden onset, we said, about type 1 diabetes. It is associated with a high incidence of complications, requires exogenous insulin, and it is usually 5 to 10% of people with type 1 diabetes, of all the people with diabetes. Again, diabetic ketoacidosis, or DKA, is emergency complication that happens with insulin deficiency. It can happen in type 1, but sometimes also in patients with type 2 diabetes. And this is when the organism starts using fats in order to get energy, because the glucose cannot be utilized due to the absence of insulin. When fatty acids are broken down while they're being used as energy sources, ketones are formed, we said. That's why it's called diabetic ketoacidosis. And ketones lead to a decrease in the pH, so that's why it's called acidosis. The patients usually have Kussmaul breathing in the later stages of diabetic ketoacidosis if they present late in the course of this complication. And it's a very bad prognostic sign for the survival of this patient. They can also have nausea, vomiting, thirst, polydipsia, polyphagia, polyuria, hypotension, tachycardia, and lastly, shock and death. Type 2 diabetes is usually characterized by hyperglycemia and insulin resistance, and it results from increased production of glucose by liver and decreased uptake by glucose in liver, muscle, and fat cells. There is also a very pronounced insulin resistance. So these patients usually will have higher levels of insulin that are circulating in their blood. And this is like a feedback mechanism in order to oppose the insulin resistance by increasing the levels of insulin in the body. Remember that patients with type 2 diabetes, they have functioning pancreatic beta cells, so they're able to produce insulin. So when there is a higher need of insulin production, they can do this, but this is not always possible in order to overcome the insulin resistance that has already developed in their cells. Type 2 diabetes can occur at any age, but usually it's after 40 or 50 years of age, and it has a gradual onset. So symptoms are not very severe initially, and they're easy to miss unless the patient goes to a physician and does blood checks like blood glucose levels, fasting, or oral glucose tolerance test. It's usually easier to control than type 1 diabetes, but in the later stages of type 2 diabetes, especially with a control of blood levels of glucose, these patients are going to get more MIs or myocardial infarctions and more strokes. More than 90%, again, of patients with diabetes have type 2 and not type 1. The causes are multifactorial. The genetic factor is very important, but there are also risk factors like metabolic syndrome, dyslipidemia, having arterial hypertension, being overweight. They all increase the risk of developing type 2 diabetes. And then we have a complication that usually happens in type 2 diabetes when there is hyperglycemia, and this leads to hyperosmolarity, and that's why it's called hyperosmolar hyperglycemia, non-ketotic coma. So we don't have ketones in this case, and this usually occurs again in type 2 diabetes due to the fact that there is still insulin in these patients. They're able to produce insulin after all. No ketosis develops, but the blood sugar levels can be over 40 or even 50 moles per liter, and this means over 800 to 1000 milligrams per deciliter. So more than 10 times the normal levels of blood sugar. And this is again an emergency situation that can result in hypovolemic shock, in renal problems, acute renal injury, stroke, coma, and even death if no measures are taken. In a hyperosmolar, hyperglycemic diabetic non-ketotic coma, when you are treating such patients, you are probably going to be working as physicians in the ER or critical care patients, or maybe endocrinologists. You should keep in mind that these blood glucose levels should be going down not very fast. So you must not be so aggressive because the patient can develop cerebral edema, coma, and then die if you go too fast when decreasing the blood glucose levels. What is metabolic syndrome? It's, I think, a very important syndrome because it combines several important disease factors that increase the risk of cardiovascular complications, and the WHO definition requires the presence of either diabetes or impaired glucose tolerance or impaired fasting glucose or insulin resistance and two of the following four things: arterial hypertension over 140/90, or medically controlled arterial hypertension, dyslipidemia, especially triglycerides over 1.7 millimoles per liter, or HDL cholesterol less than 0.9 for males or less than 1 millimole per liter for females. Central obesity, again, here we have a difference between males and females, and also between the Asian population and non-Asian population, or microalbuminuria, which is the presence of albumin in the urine, or also there is a ratio of albumin to creatinine. When this is over 30 milligrams per gram, this is also called microalbuminuria, and this is enough to make the diagnosis of metabolic syndrome. Again, it's a very important syndrome because it combines several important things like dyslipidemia, being overweight, having hyperglycemia and hypertension, which all lead to an increase in the risk of getting myocardial infarction, stroke, and other vascular complications. And due to the modern lifestyles that we all have, and less physical activity, more fast food type of eating, this is a syndrome that is going to be even more and more commonly seen in our everyday practice. What are the hypoglycemic drugs in order to treat these conditions? For type 1 diabetes, it is of course insulin. So all patients with type 1 diabetes will require insulin. But for type 2 diabetes, especially in the first couple of years after diagnosis, we have other options, which are oral drugs. And then if these drugs and their combinations are not enough to achieve euglycemic levels, then also they can be combined with insulin. So in type 2 diabetes, we can also use insulin. Age-related considerations in children, you need to keep in mind that you need to have a very good communication with your patient because they sometimes do not accept the fact that they're sick, which is absolutely normal. But if you are able to explain the disease itself and what may happen when they're not taking their insulin and not following the advice, then they start understanding better the disease itself, and they're also more compliant, and they get better results. If you are interested, there are also many sports players, basketball players, every type of professional sports players that have diabetes type 1, and they can compete at very high professional levels. And if, let's say, you're a pediatrician and you want to give a child with type 1 diabetes, such an example, with someone, let's say, from like a basketball player or a football player, then you can also win the support of the patient itself, and have better communication and better understanding with your patients, which are, again, very, very important, sometimes more important than um, the drugs themselves, because if you prescribe the best drugs and the best their insulin pumps, for example, but the patient is not compliant, then the results uh, are always going to be bad, no matter what you're doing. Children are also more susceptible to dehydration in type 1 diabetes, so adequate rehydration is very important. Rotation of sites for insulin injections is also very important, and you should avoid hypoglycemia, but also hyperglycemia in infants and young children in order to avoid damaging effects on growth and development, because, as you know, during this age, children develop very fast. What are the symptoms of hypoglycemia in children? Well, they can feel hungry, they can have sweating, tachycardia, they become more irritable or lethargic in the later phases. That's why close monitoring of blood glucose levels are very important. Again, there are insulin pumps that can be implanted under the skin, which are able to measure the blood glucose levels, and they can administer insulin as per the need of the patient. Human insulin is actually chemically identical to the endogenous insulin. That's why it's called human insulin, but it is not derived from human pancreas. It is just a genetically made peptide that is administered subcutaneously, but also intravenously. It cannot be given orally. And of course, there are different types of insulin. Human insulin is just one type. It is usually divided into ultra short acting, short acting. Human insulin is usually short acting in this classification. Intermediate acting and long acting insulin. Rapid acting insulins have a very rapid onset, and they also have a short duration of action. So they start working in 10 to 15 minutes after administration, and they're mostly effective in decreasing postprandial hyperglycemia. So when patients are going to eat, it's a good idea to administer 10 minutes before eating a rapid acting insulin. And this happens usually 3 times a day in most patients who depend on insulin. Short-acting insulin, it's also called regular insulin or uh, human insulin, and these are the trade names like Humulin R, Novolin R. They're given subcutaneously, but also they can be given intravenously as an intravenous drip. Then we have the intermediate acting insulins. It's usually called MPH insulin. It has a more slower onset and a longer duration of action. And then we have the long-acting insulins like insulin glargine and insulin detemir, which do not have a peak in their action. So the risk of hypoglycemia is low. And the idea behind using long-acting insulins is to keep the higher levels of blood glucose during the night. Let's say there are no peaks and no troughs, so the blood glucose levels are usually not going up and down. They're usually pretty constant during the night, but in patients with diabetes who have bad control and who need insulin therapy, these levels are constant at a high rate, let's say 8 or 9 millimoles per liter. In order to bring this down without having the risk of causing hypoglycemia, because during the night the patient is not getting food or drink, usually we use long-acting insulins. There are also insulin mixtures like MPH, 70% to 30% of Humulin or Novolin, and the durations of actions are the same as the individual components of these insulins. Lispro and Aspart, they are fast-acting, rapid-acting insulins, and insulin glargine. The trade name is Lantus. Again, you don't need to know the trade names. I'm just giving you examples because I ensure that when you're talking to patients, sometimes you see Lantus or they tell you a trade name. That's why it's a good idea to know some trade names sometimes, but you're not going to be asked in the exam for any trade names. Oral hypoglycemic drugs, we have very different classes to treat type 2 diabetes mellitus. Sulfonylureas are the oldest oral hypoglycemic drugs, and they're called insulin secretagogues because they lead to an increased secretion of insulin, unlike metformin, which is called an insulin sensitizer, because it does not increase the secretion of insulin, but it increases the receptor's sensitivity to insulin. So the sulfonylureas, they lead to a secretion of insulin. That's why they're called secretagogues. And also there is a decrease of production of glucose in the liver. So gluconeogenesis is lower. And of course, they're effective only if we have functioning beta cells. So the sulfonylureas are not going to be effective logically in type 1 diabetes. The very commonly observed adverse drug effect is hypoglycemia, which is more commonly seen in these drugs than in insulin sensitizers, because again, they lead to an increase in the secretion of insulin. The sulfonylureas are divided into first generation and second generation. We primarily use the newer generation of sulfonylureas like glipizide, gliburit, or glimepiride. Again, these are some trade names that you've probably seen. Also, sulfonylureas can be combined with metformin, which is the drug of choice in type 2 diabetes, and they can be used in a lot of different patients, but you need to be careful in patients with renal and hepatic failure. and also they are contraindicated in pregnancy. In pregnancy, usually people who have diabetes to a therapy with insulin, at least during the pregnancy, and do not use any or almost any other anti-diabetic drugs. Another drug class that is oral type 2 diabetes drug is the alpha glucosidase inhibitor class of drugs like acarbose and miglytol, and they inhibit this enzyme called alpha glucosidase that is found in the GI tract, and they break down complex sugars into simple sugars that can be absorbed in the gastrointestinal tract and go into the bloodstream. So when this enzyme is blocked by the alpha glucosidase inhibitors, so less sugar is being absorbed in the gastrointestinal tract, so less sugar goes to the bloodstream. These drugs are contraindicated in cirrhosis, in malabsorption, and also in severe renal impairment. They should be taken at the beginning of each meal, and because they lead to more starch and more complex sugars to be left in the gastrointestinal tract, they usually lead to bloating and diarrhea in patients with diabetes. The big one-ites, and here the major example is metformin, which we said is the drug of choice in type 2 diabetes. They do not increase the insulin secretion. However, they increase the sensitivity of insulin receptors to insulin. So it causes a better usage of insulin and better entry of glucose by to muscle and fat cells. And the risk of hypoglycemia with metformin and other insulin sensitizers are very, very low as compared to other drugs like insulin secretagogues, like sulfonylureas, for example, that we said, which have a higher risk of causing hypoglycemia. The major adverse drug reaction of metformin is lactic acidosis. So in order to avoid lactic acidosis, you should be very, very careful in people who have renal impairment. So if the creatinine clearance is below 45, but especially if it is below 30 milliliters per minute, the creatinine clearance, then metformin is contraindicated. So don't use metformin in patients with terminal end-stage renal disease or in patients with a very low creatinine clearance. And you must always check renal function before beginning therapy with metformin. Also, metformin should be stopped before using contrast agents. Let's say a CT scan with contrast or coronary angiography that use contrast media that contain iodine. You should avoid using metformin 24 hours before and 24 hours after the procedure, usually in order to avoid renal injury and also lactic acidosis in patients who are on metformin. The glitazones, which are also called thiazolidinones, like pioglitazone and rosiglitazone, they're rarely used drugs nowadays because in people with heart failure, they have been shown to increase the risk of cardiovascular events. And as you know, a lot of people with diabetes have cardiovascular issues. So that's why they're relatively rarely used nowadays. But another thing to keep in mind about these class of drugs is that they're insulin sensitizers and they're not secretagogues. They're also contraindicated in liver failure. And also we said about heart failure that you must not use them. The next class of drugs are called meglitinides, and the examples here are nateglinide and repaglinide, and they are again drugs that stimulate the release and secretion of insulin by the pancreatic beta cells, and that's why they're called insulin secretagogues. They can either be used as monotherapy or in combination with metformin, and again, they should be taken before eating a meal in order to avoid hypoglycemia. Some herbals and some dietary supplements can affect blood glucose levels, like bee pollen, the ginkgo biloba, and glucosamine, and these are some supplements that are used especially by elderly individuals. They're thought to increase actually the blood sugars, and they may also potentially affect beta cell function and insulin secretions. So it's not a very good idea to take so many dietary supplements and herbals. Um, you should always base your decision on um, medical evidence and avoid using drugs that do not have enough evidence to support their use. In diabetic ketoacidosis, we said that patients will need IV fluids to rehydrate, potassium supplementation because they usually have a decrease in potassium levels, insulin, drip. In this case, we usually use human insulin, which is the regular insulin, the fast-acting, actually the short-acting, not the rapid-acting, the short-acting insulin. And we need to do this by gradually lowering the blood glucose levels, not very suddenly, in order to avoid complications. In hyperosmolar, again, diabetic non-ketotic coma, we need to treat the patients very similarly as those with diabetic ketoacidosis. So we said DKA, mostly seen in type 1, and hyperosmolar is mostly seen in type 2 diabetes. But the most important thing to keep in mind again is to very gradually lower the levels and not be very aggressive. Here are some other important points, like mixing insulins. It's not a very good idea. You need to use also, you need to be very careful. For example, before surgery, it's very much advised that the patient do not use their insulins, and mild to moderate hyperglycemia is allowed before surgery because these patients usually do not eat. So it's not a big problem for the patient to have a little bit higher levels of blood glucose, let's say around 10 millimoles for the first part of the day before the surgery is done. In patients with insulin pumps, we use regular insulin or human insulin, which is the short-acting insulin, or insulin aspart, which is rapid-acting insulin. And usually these pumps will deliver 1 unit per hour with bolus insulin before meals. And these pumps are actually very helpful in the treatment of diabetes. Tight glycemic control is very important in order to reduce the complications of diabetes, and also the usage of ACE inhibitors. If you remember, in patients with diabetes, we prefer to use ACE inhibitors, especially if they have arterial hypertension, in order to delay diabetic nephropathy. Okay. So the second part of the presentation is about some guidelines. So if we want to decrease the levels of glycated hemoglobin by less than 0.5%, then usually diet is is enough, and also if it's not enough, metformin usually does the job. But if the patient has very high levels of blood glucose, so the glycated hemoglobin is very high and we need to decrease it by more than 1.5%, then usually metformin and some other agents, either second or third drug, should be used. Here is a algorithm of which drugs can be used along with metformin. A very important question to ask is if your patient has any clinical cardiovascular disease. If the patient has clinical cardiovascular disease like peripheral arterial disease, past stroke, or recent MI, let's say, then it is a very good idea for this patient to be on empagliflozin, liraglutide, or canagliflozin. And EMPA and canagliflozin, they are actually SGLT2 inhibitors, which have a very important place also in the treatment of heart failure patients with or without diabetes mellitus, if you remember from our um, first presentations. Why do we prefer empagliflozin in patients with cardiovascular events? Because as you see here, this is a 4-year clinical trial, and there are two groups, one on placebo, one on empagliflozin, and you see that the first group that is on empagliflozin, after 3 months, these two lines of placebo and empagliflozin are already divided. So people on empagliflozin are getting less cardiovascular complications, and this is so uh, early in the course of treatment. And at the end of 4 years, you see that this difference is even greater. The same goes for liraglutide. The negative side of liraglutide is that it is an injectable drug. It is injected subcutaneously, and it is injected usually 1 times per week. For some patients, it is more comfortable. For others, not so. So you should talk to your patient also and see what he or she thinks about getting an injection every week or getting a drug every day, an oral drug. This table and the next one that I'm going to show you, they are very important, and again, they will help you for the exam. I'll send you the presentations if you want to prepare by using the presentations, but in the exam, you may get asked some questions like which drug groups that are used for the treatment of diabetes have a positive side effect in terms of weight loss in patients with diabetes. And you see that in patients who are on GLP-1 agonists or SGLT2 inhibitors, like the two drugs that we mentioned, cana and empagliflozin and liraglutide, they have a positive side effect of reducing the weight of these patients. And this is very, very important in type 2 diabetes because usually they have metabolic syndrome. So this means that usually they're overweight. But when they get to insulin, and at some point of time, let's say after 15 or after 20 years of having diabetes, they get to a point in which they require insulin. They usually start gaining weight after several months of treatment with insulin, and this is a negative side effect. So such questions you may get asked in the exam. Keep this in mind. Also, another very important table. This shows you which drugs are safer in terms of renal function and which drugs are contraindicated in renal failure. You see that glyburate, it's absolutely contraindicated in patients with lower than 60 milliliters per minute creatinine clearance. And here you see the EGFR and the stages of CKD, so chronic kidney disease. Stage 1 or 2, they're usually over 60 milliliters per minute. In stage 5, which is less than 15 milliliters per minute, they usually require either kidney transplantation or hemodialysis. Again, metformin, we said below 45, use with caution and at lower doses, so from 500 to 1000 milligrams per daily. It is with a maximal recommended daily dose of 2.5 grams, so 2500 milligrams per day. But if your patient has a creatinine clearance of below 13, do not use this drug. Again, here another very useful table that you can use for the exam when you're preparing about the different types of insulin. So rapid acting insulins, short acting insulins, basal insulins, which include the intermediate acting and the long acting insulins, the duration of action, the peak effect, and the onset of action. Key messages for your patients with diabetes. First line glucose lowering medication in type 2 diabetes is again metformin. But metformin should be used very carefully. You should always check the renal function before starting treatment with metformin, and then follow up your patient if you've achieved normal levels of blood glucose, and follow the kidney function. So this was the last slide for today. I hope you've remembered some things that you already know, and you've even learned some new things. And if you have any questions, I'm open to answer them. I'm sorry for keeping you so late on Friday, but this is unfortunately the program for this year. So we have, I think, 2 more weeks, and then you'll be in exam session. I hope you're going to be great in your exams, also in your clinical pharmacology exam. We can do another test maybe that is going to prepare you better for the exam, but let us first finish the exercises, and then we're going to talk about preparation for the exam. Maybe we can go over some important questions with some of you who would like to prepare for the exam better. Okay, so I don't see any questions, guys. I wish you a happy weekend. Stay safe, and see you next week at around 5:30. Again, I hope to be here earlier, maybe around 5, but I don't promise you. So check your program, and I'll see you guys next week. Bye-bye.
You are currently the only person in this conference.